Hello, everybody, and welcome to this event. My name is Giovanni Torsello, vascular surgeon from Germany, and I would like to welcome you to this web live symposium, which is dedicated today to the costs of target lesion revascularization after bare metal stent. The symposium is supported by Boston Scientific, and today I would like to welcome two experts of this staff who performed one very interesting trial just published in the European Journal of Vascular and Endovascular Surgery. Dr. Athanasios Saratsis from England and Dr. Konstantinos Stavroulakis from Germany. I would like to encourage you to participate actively to this event. So if you have questions, if you would like to express your opinion on this stuff, please make your question, and I collect every question at the end. And I would like to start first with a short presentation by Professor Saratsis, who will show the background, also the results of this interesting study.
Great, thank you very much. And again, welcome everyone. I'll go through the results of this study. You can find the full paper as per Professor Torsello's introduction on the European Journal of Vascular and Endovascular Surgery. It's only been published a long while ago. So our study is called the Costly-TLR Study, and I'm just going to go through some pertinent points of what we've just published. These are my disclosures. Very important to say that this work was supported by Boston Scientific, but the collection and analysis of data has been or have been performed completely independently, led by a separate group of us in Leicester as well as in Germany, so myself as well as Kostas Stavroulakis. The Costly-TLR study, some details about the structure of the project. This was a pan-European study. Many centers have taken part, and we're looking at all comers, so consecutive patients requiring femoral popliteal TLR in between 2017 and 2021. In essence, this was a micro-costing exercise. We collected a lot of data regarding the clinical presentation, as well as the actual procedures that these patients underwent when they had their first procedure, as well as when they had the TLR. So the research question of the study was, what is the exact cost of a FemPop TLR when a patient had previously been treated with a bare metal stent, and thus a bare metal stent involving the SFA or the popliteal artery? The primary outcome was the exact cost from presentation until discharge in euros from a healthcare payer's perspective. And the costs were analyzed per constituent, and this included the costs of any form of equipment, as well as other indirect and estate costs that would incur due to the fact that the patient was an inpatient for at least a few hours in order to undergo their TLR. We also looked at the clinical characteristics of these patients and reported early clinical outcomes perioperatively, as well as a few days after the actual procedure. So the important points: what is the cost of FemPop TLR when someone has had a stent before? And that's the cost from presentation until discharge in euros from a healthcare payer's perspective when they're having their actual TLR. These are the centers that took part from Germany, the UK, Italy, Spain, Belgium, and France. So a big study, all comers undergoing clinically driven FemPop TLR. A total of 482 patients were analyzed from all of these sites, and as I mentioned before, these are patients who have had a stent before. About half of them were females, which is an interesting finding in itself. 61% when they presented for the TLR, Rutherford class 5 and 6, so pretty advanced disease. And we're looking at predominantly Tosaka class 3 disease when they present for their TLR. Only 6 of them underwent open surgery exclusively, and 52% underwent a hybrid procedure. 30-day death rate of 1%, 30-day major amputation rate 4%. These are the characteristics of their disease when they presented for their TLR. The popliteal artery is the one that was mostly affected, and most of the patients presented with Tosaka class 3, so pretty bad in-stent disease after their original procedure. These are the treatment strategies and the characteristics of exactly what took place during the TLR procedure. We're looking at a duration of about 80 minutes. We're looking at mean counts and standard deviations or absolute proportions. So the duration of the TLR was at about 80 minutes for all of the patients. And then we're looking at the number of bypasses, and we're looking at the number of other procedures like common femoral endarterectomies, thrombectomies, etc. Now, some important numbers. If we look at the endovascular components or the endovascular procedures that were performed, we've got quite a lot of atherectomies being performed at about 25%. But most importantly, this is not just an atherectomy procedure. Whenever we're performing a hybrid or an endovascular procedure, we're looking at a combination of endovascular treatments like POBA being used with atherectomy, with DCB, plus minus a new stent. So these are complex TLR procedures. Another very interesting finding is the fact that 63% of these procedures required a general anesthetic, even though lots of them only involved an endovascular component only. So again, we're looking at complex procedures that are taking quite a lot of time. These are the costs per type of TLR. And what I would like to draw your attention on is the fact that we've split them per procedure. So we've got all of the procedures here on the first column, open procedures and endovascular hybrid procedures. The most important constituent or the highest cost was incurred by the fact that these procedures were taking quite a lot of time. So you're looking at a cost of about 21,000 euros due to the duration of the procedure. What does that mean? This is the cost incurred in order to pay all of the people that are present in the operating theater or the angio suite, as well as to pay for the cost of the angio suite or the operating theater running for 80 minutes or so. These costs were higher for open treatment and lower for endovascular treatment. This is another important slide. Here you're looking at, I know it's a busy slide, but there's no other way to break this down. You're looking at the equipment costs. This is what the hospital actually paid for the equipment that was used during those TLR procedures. And as you can tell, these are complex procedures requiring all sorts of things like DCBs, new stents, atherectomy devices, and filters to be used. Now, the other thing I'd like to draw your attention to is the fact that even though we're using all sorts of complex endovascular equipment, the cost of that equipment is at about 3,000 euros. So much higher than the cost of actually being in theater for about 80 minutes or so, which was at about 20,000 euros per case. So the operating time is really what is driving the cost of the TLR, not the use of certain devices like wires, closure devices, etc. It's the cost of the operating time that's really driving those costs up. So the question remains now, How can we prevent TLR? We've shown in this study that the cost of a TLR in an all-comers population across Europe is at about 20,000 to 23,000 euros per patient. It's mostly being driven by the fact that these procedures take a long time in the operating theater. It's not driven by the cost of the additional endovascular devices or the inpatient stay. So how are we going to address this problem in the future?
Thank you very much. What a really excellent presentation, and we really appreciate your efforts to make this very complex trial a successful one. Now I would like to ask Dr. Stavroulakis if he has any comment on this trial, and also what we learned from this trial.
Thank you, Professor. Thank you also, Thanos, for the excellent presentation. And I'm really glad to see that this project really happened. It wasn't that easy because a macroeconomic analysis is very tough for various reasons. First of all, you have to calculate costs that are not very easy to calculate, like how much money costs for the hospital a minute in the operation theater. So this is a very difficult question, and it was not that easy to answer in many different hospitals. What I see, and after the findings of this trial, is first of all that TLRs are very expensive, especially when you have a primary stent deployment. We don't know how much a non-stent TLR costs, but based on the findings of this trial, we see that TLRs after stent placements are very expensive. And what I really understand now is that we have to try to do it right from the first time, because every TLR is much more expensive than any other material that you can use during an index procedure. So sometimes people say that we avoid the use of IVUS, for example, because it costs 800 euro. But if this reduces the numbers on the rates of TLRs, you can imagine how much money do we save. And this is just an example. I'm not saying that IVUS is cost effective, but it's an example that we try to save money from the index procedure, but we create a much more expensive TLR. And the second thing is that sometimes I think that health economic analyses that are performed, and when we talk with administrations, all these analyses are performed and based, or most of them are based on the DRGs and not on the actual costs. And you see a huge gap between the DRGs and the cost of the hospital. And this is something that healthcare professionals and healthcare payers have to understand. Like the actual cost and the DRGs are two different things. We're trying to understand more about the health economics and how things should change. But I think that this trial was a step into the right direction.
Excellent. Thank you. Meanwhile, I have the first questions on my screen. One question is primary bare metal stent or PTA with bailout bare metal stent feasible? Should we do it in our practice? Or based on these results, should we switch directly to drug-eluting stents?
Hannes, do you want to answer, or should I go for it?
Yeah, that's an interesting question. We need randomized data in order to be able to understand that. The Basel III trial is coming out in a few days. Is it going to answer all of these questions? Well, probably not. What we are showing here, though, is the fact that TLR rates are quite high, and a TLR is an extremely expensive thing when it does occur. Bare metal stents have also come a long way. You've got new generation stents out there, those biomimetic stents. And mind you, we are stenting because the lesion was complex to start with. So it is a very difficult question to answer. What we have done here is we've tried to understand the actual cost of a TLR. We need high quality effectiveness-driven randomized data to fully answer the question between the performance of bare metal stents and the newer generation drug-eluting stents. And I can tell you, even after the Basel III study, You are not looking at biomimetic stents in Basel III. You are not looking at the latest generation devices. So hopefully in the future, we'll have some form of more complex study that will be able to address those things in real time.
Dr. Saulakis, you were involved in the EMINENT study, which is a prospective randomized study comparing Eluvia drug-eluting stent with any bare metal stent, collecting data of, if I remember right, more than 700 procedures done, showing also the superiority of drug-eluting stents. What is your opinion? Should we use drug-eluting stent also from the background of the results of this study, of the Costly study?
I think there are two different studies, so we have to differentiate that. The Costly-TLR was not made in order to understand what kind of index procedure do we need. This is an answer that should be answered in the framework of another trial. We just want to know how much do we pay when a stent goes down. This is something completely different. The EMINENT trial was a very good randomized control trial, core lab adjudicated, etc., which showed that Eluvia has better patency rates compared to non-drug-eluting stents or bare metal stents. So I think that Eluvia is a very good option compared to other compared to non-bare metal stents, but it doesn't mean that we should not use bare metal stents, especially not because of the findings of the Costly-TLR. I think we should decide based on lesion morphology, lesions location. If we use a bare metal stent or spot stenting, probably after DCB, it's a very complex question to be answered, and I think that it cannot be answered just based on the findings of a single trial. I totally agree with Thanos that Basel III will enlighten some of these questions that right now are not answered. We have the body of evidence for Eluvia, which support its use, but still there are many things that aren't clear regarding the index procedure. So I don't think that the Costly and can really change our algorithm regarding the first procedure. It just shows that do it right in the first time. What is right for you or for the patient, it's a physician-made decision.
Okay. Professor Saratsis anticipated the next question coming in. What are your predictions for Basel III?
It would be daft to share any form of prediction. What I can say about Basel III, much like Basel II, it was not very easy completing the study. And what I hope will happen in the future is that all of us will come together and realize that we really seriously have to fund and deliver those big, difficult studies in the PAD environment. Otherwise, we'll be here in 5-10 years' time talking about the same things over and over again.
Dr. Stavroulakis, your expectations?
I think that many things happened, the last 6 years. I think the first thing that happened was Katsano's meta-analysis that really changed the way that we see studies nowadays. Regardless if we think that paclitaxel has an impact or not, I think this is answered. But the core of this meta-analysis was that it questioned these trials. The data collection process, the quality of the data that we had, etc. And I think that now we have to push both the industry partners and the societies to fund proper large-scale studies. When I started writing papers, in every sentence at the end, I was saying, I was right. It's a very nice study, but we need large-scale studies to confirm these findings. And these studies never happen. So I don't know if I can expect it, but I hope and agree with Thanos that we, as vascular specialists and societies, will manage to perform the same quality of studies that the cardiologists do, oncologists do, even general surgeons do. So we have to change our expectations and to push for meaningful studies.
Okay. Dr. Saratsis, what was the rate of patients which had to go to the ICU in this study, and why?
Yes, that's an interesting question. I will have to look at the actual diagram to make sure I'm not lying. And people can find all of the exhaustive details in the EJVES paper, which was recently published. I believe that rate was at about 6 or 7%, not extremely high. But again, people are saying, oh yeah, it's just a TLR. They're coming in for a few hours and they'll go home. Well, it's not as simple as that. And you saw that more than 2/3 of these patients are having a general anesthetic. The other thing to say here is that the cost of ITU was less than the cost of the operating time per se. So it's the operating time that's really costing a lot of money to the healthcare payer. And one more detail about costs, what we've reported here, it's only healthcare payer related costs. The overall cost to society and to the patient is much higher because the patients come in for a few days, they're losing income from their jobs, they're not able to perform their usual activities, so society overall incurs higher costs.
The ICU beds, something that I personally realized during the COVID period was that when a patient goes for the ICU for an unplanned procedure, it blocks a bed in the ICU, which might be needed from another patient who has needs an urgent procedure, which means that for every patient what we saw during the COVID time is that the rates of heart death for PCIs was much higher than prior to COVID because the patient didn't have an ICU bed. So even if the costs of the ICU are not that high, or even if you don't have so many patients going to the ICU, imagine how many patients we could have saved if the index procedure was better. Because then we wouldn't need these beds and we wouldn't block these beds for patients that they really need them. And this is what Thanos says, that the society costs are completely different. We have to calculate many different variables that we cannot, of course, calculate in the framework of this kind of analysis, but the costs of the society are much higher than the ones that we calculate with the Costly-TLR.
Okay, thank you. Another question coming in is about the SPORT trial. This was recently the results were showed by Dr. Tepe, comparing drug-eluting stent, bare metal stents, and DCB in a prospective randomized way. Can you comment on the results? The preliminary results.
Also, very interesting study. We don't have many studies comparing 3 different arms, and this is something that we have to congratulate the colleagues that performed the study. Again, I think that we have to decide for our patient based on many different parameters, lesion characteristics, patient, etc. For example, if I have a task A lesion, probably I wouldn't use a drug-eluting stent. On the other hand, if I have a very long lesion, probably I would prefer drug-eluting stent. On the other hand, when you go deep the popliteal artery, I would prefer an interwoven stent deployment. So we need these kind of studies, and they're important, and they provide us evidence that we didn't have before. But still, it's very difficult and complex to develop an algorithm how we should treat PAD patients endovascular for FEMPOP lesions. It's not a matter of a single study. And we have to work all together, as Thanos said before, to create these studies that will help us build this kind of algorithms.
Okay, one question coming from Saudi Arabia is directed to Dr. Saratsis. Is there any future comparison between instant restenosis cost and drug-eluting balloon TLR or debulking devices TLR in SFA occlusion?
Yeah, we're not immediately planning to do that ourselves. It's a very good question. Yeah, I'm afraid there's no immediate SATS plan using this specific data set that we've got access to. We were not looking specifically into the type of vessel preparation that was used in the index procedure prior to the TLR. And we have got the data, though, to look at what kind of vessel preparation, if any, was used during the TLR procedure. And actually, this question probably does relate to the sports trial as well. Because again, in the sports trial, which is efficacy driven, of course, you haven't really got vessel preparation into the equation of this 3-arm study. So that's the next step generally for the community. We've now got great vessel preparation tools. I think we need to start looking at how they fit in the algorithm of our decision making, like Kostas mentioned earlier. Very difficult to do that in a study because now we're looking at 3 or 4 different vessel prep devices, plus minus a DCB, plus minus a DES. Very difficult questions to answer, but something for the future, yeah.
I have one last question for Dr. Stavroulakis. What is the role of vessel preparation for reducing the rate of TLR after stenting? And which time?
We don't really know. You know, when the vessel prep term first developed, it was like trying to describe all these things that we're doing besides POBA to improve the rates of, to improve the outcomes of DCBs. What we now understand is that vessel prep is important regardless what we do afterwards, if it's stenting or DCBs, or both, sometimes because you combine both. We have some data from the Supera trials, which again are non-randomized, single-arm trials, etc., which shows that if you prepare the vessel properly, then the outcomes Supera are much better because you can deploy the stent better. And now we run a trial with a combination of IVL and Eluvia stent for heavily calcified disease, which is a prospective single-arm study, which will show us the benefit of IVL prior to Eluvia. Unfortunately, we don't have many trials looking at this question, but I think that we all understand that the use of vessel prep devices are crucial regardless what we do afterwards, if it's DCB or stenting, because you have better luminal gain, and even if you stent, then the stent will expand better. And for DCBs, I think that we have many trials showing that the vessel prep might improve the long-term outcomes of paclitaxel-coated balloons.
Okay, excellent point. Thank you so much. I think we have to close the session now. I would like to thank you for your contribution, Professor Saratsis and Dr. Stavroulakis, and also to the participants for the interesting questions you proposed. Thank you so much, and I see you soon. Thank you. Bye-bye.
Goodbye, everyone.